And he was treated, as you noted, with 2 milligrams per kilogram of prednisone. Uh, why don't you tell us, is that the approach you would take, or what other things could you consider?
Well, this is the approach that I will take with this man. And, I paused a little uh, because if this is the only problem that we are dealing with at this time, then I will indeed start with 2 mg per kg of prednisone. As I alluded earlier, I came from a T-cell depleted institution where uh, viral infections were very high, and oftentimes we will have a similar case with CMV viral load of something in the 50,000. And giving that much steroids can get the CMV or other viruses out of control. So for a case like that, we can start at a lower dose, typically either 1 mg per kg or 0.5 mg per kg, and see what happens. The caveat to this is if he responds, great. If he doesn't respond, you will have to up the dose and start over again before before judging whether he is steroid refractory or not. So again, I like to believe that there's still some art of medicine in what we do.
So what would you say is the likelihood that someone like this with very straightforward grade 2 GVHD will be steroid responsive? And what's the likelihood that they'll be steroid refractory?
So it's a 50-50. So in about 50% of the time, he will be steroid responsive. You taper the steroids over a long time, and graft-versus-host disease will not come back. So that's a 50% chance. The problem is the other 50% where he either does not respond and falls into a steroid refractory acute graft-versus-host disease. After 3 to 5 days, his GVHD progresses, or he does not, or stays the same after a week, or does not resolve in 4 weeks. That's basically the definition of steroid refractory acute graft-versus-host disease. So, or he responds, you start to taper the steroids, and once you start to do that, the diarrhea increases or he has more rash. So that becomes a steroid dependent. So in 50% of the time, he will fall into one of these 2 categories, either steroid non-responsive or refractory, or steroid dependent.
Do either of you use biomarkers to either guide initial therapy or guide response to therapy? Or is that something that's just for clinical trials?
I have used it a couple of times, I must confess, in a very inconsistent way for reasons that probably outside of this discussion, and insurance and other logistical issues. But, the 2 main biomarkers, ST2 and REG3 alpha, have shown over and over a benefit. And again, I come from New York. I worked across Central Park from Mount Sinai, where the biomarkers were very popular there.
I don't use them. I think they're experimental, and I don't think that their ROC curves are impressive. So, I don't think that they've been validated prospectively either. So for all of those reasons, I don't. But then, I respect other positions, but they're all that we have now to give us some guidance in a way. So, I'm not, by saying this, I'm not, being critical to those who use it. It's just that, you know, I feel that they need a little more work before I start considering them standard of care.
And that's largely the approach we have here in Boston. We utilize them when they're part of a clinical trial, but we don't use them outside of a clinical trial for routine care at this time. That's sort of been our approach.